Assalamu alaikum and welcome back to Pete's Mentor. I am Dr. Atif Raza and today I am covering a very important neonatal topic, that is hyperbilirubinemia in preterm infants under 35 weeks gestation. This is one of those topics where mistakes happen when people try to use the same mental model for all newborns. A very preterm baby is not just a smaller term baby. The physiology is different, the vulnerability is different, and the treatment threshold are also different. So, starting with why these infants are more vulnerable. So, first one, we are starting with a question, why preterm infants are more vulnerable. As you all know, that premature babies have immature organs. So, bilirubin binding is less reliable and the brain is more susceptible to bilirubin injury. On top of that, these babies are much more likely to have sepsis, acidosis, respiratory disease, temperature instability, poor feeding, and hemodynamic compromise, all of which make bilirubin more dangerous. So, we have preterm babies which have immature organ system, resulting in more susceptible neonates, which can lead to brain injury at a very low level of bilirubin. So, throughout this session, keep one central idea in mind. In preterm infants under 35 weeks, bilirubin must always be interpreted in the context of gestational age, clinical stability, and neurotoxicity risks. So, here we have to consider 3 points. First one is we always check bilirubin level in context with gestational age. Second one, with clinical condition. And the third one is risk of brain injury, that is neurotoxicity risks. So, today in this lecture, I will build a full framework around the gestational age based table from Gomila's Neonatology, which matches the widely used preterm consensus approach. So, here I am delivering this lecture mostly based on Gomila's 8th edition. So, starting with the first question, why preterm babies are different? Why preterm babies are different? As I have already told you that preterm babies have immature organs, and we all know that newborn babies develop jaundice because bilirubin production is high, hepatic conjugation is immature, and enterohepatic circulation can increase, especially when feeding is poor. But prematurity adds another layer of vulnerability. So, in premature babies, one of the risk factor is itself prematurity, and other risk factors are the same, that is high bilirubin production, increase enterohepatic circulation, and decrease conjugation because of immature liver. So, in preterm babies, hepatic cells are more immature. So, there is more hepatic immaturity in preterms, especially in sick ones, so resulting in decreased conjugation and decreased clearance. Second one is reduced reserve in bilirubin binding. So there is reduced reserves of bilirubin binding. In preterm babies, especially in the sick ones, bilirubin binding to albumin is less dependable. So free bilirubin becomes a bigger concern. The third one, which is the major issue, is neurological vulnerability. As you all know, the more premature baby, the more immature brain is. So the blood brain barrier is immature here, which lowers the margin of safety. So here is due to immature brain or immature blood brain barrier. And the fourth one is clinical condition. As we all know, preterm babies often have the very condition that make bilirubin more dangerous, such as sepsis, hypoxia, acidosis, respiratory failure, poor feeding, delayed stooling, and hemodynamic instability. So, in a preterm baby, the bilirubin number never stands alone. The same total serum bilirubin may be tolerated in one infant and dangerous in another, depending on maturity and clinical condition. This is why the preterm approach is not just what is the bilirubin. So, here, approach is different and it depends on many factors such as how premature is the baby, how clinically stable is the baby, are there risk factors that make bilirubin more dangerous, and where does this bilirubin sit for that gestation. So, here we have to identify all these factors to deal jaundice in preterm. So, starting with the practical point and answering one of the most important question in preterm neonates, that is, why do many clinicians prefer a gestational age based table? Why it is so? Because gestational age reflects biological maturity much better than weight alone. It reflects liver immaturity, bilirubin binding maturity, blood brain barrier maturity, and overall neurological vulnerability. So, greater the gestational age, greater will be liver maturity, greater will be bilirubin binding, greater will be blood brain barrier maturity, and lesser will be neurological damage. For example, two babies can have similar birth weights and still be very different in maturity. That is why this gestational age based approach is so practical. It helps you think in a way that matches the physiology of the infant in front of you. So, let us move to the table, which is basically gestational age based threshold table. So, For easier approach, just remember one point: lesser the age of a neonate, the bilirubin level would be less for their vulnerability. It means if a neonate which is less than 28 weeks, the threshold for phototherapy is approx 5 to 6 milligram per deciliter. This is for phototherapy. And for exchange transfusion, it is approx 11 to 14 milligram per deciliter for exchange transfusion. As we increase in age, this levels also increases and this threshold increases because liver matures more, bilirubin binding improves, blood brain barrier maturity improves. For 28 weeks till 30 weeks, this threshold increases for phototherapy as well as for exchange transfusion. For phototherapy, it increases up to 6 to 8 for phototherapy, and for exchange transfusion, the threshold increases to 12 to 14. I will also discuss why there are two values, one is less and one is on higher side after this. Now after this, from 30 week till 31 week 6 days, that is you can count as at 32 weeks, the values increases further. That is for phototherapy, it increases up to 8 to 10, and for exchange transfusion it increases up to 13 to 16. For 32 weeks till 34 weeks, that is 33 weeks 6 days, this increases further. For phototherapy it increases up to 10 to 12, and for exchange transfusion it increases up to 15 to 18. Look at the pattern: lesser the gestational age, lesser the threshold to start phototherapy or to have exchange transfusion. As the gestational age increases, this threshold values also increases because of the reasons written over here. Liver maturity improves, bilirubin binding improves, blood brain barrier maturity improves. So the last one, which is 34 weeks till 35 weeks, 34 weeks 6 days, it improves further, and the phototherapy threshold for this is 12 to 14, and exchange transfusion is 17 to 19. So if you look at this pattern, you have an idea that as the gestational age rises, the threshold also rises. So that is exactly what should happen. A 26-week baby is more vulnerable than a 34-week baby. So there should be different treatment plan, approach plan for both of these babies. So remember the simplest rule: the smaller and more immature baby, the lower the threshold. So one question might be in your mind: would you have to memorize all these? For me, you don't have to memorize all these values, but think it like a staircase, just like I am drawing over here. Let's suppose here is a baby which is less than 28 week. So you should have in mind that these babies are vulnerable at a level of 5 to 6 milligram per deciliter for phototherapy and 11 to 14 milligram per deciliter for exchange transfusion. As we are increasing in the gestational age weeks, 28 till 30, these values also increases. From 5 to 6, it becomes 6 to 8. From 11 to 14, it becomes 12 to 14. From 30 week, here is 29 week. From 30 week till 31 week, this also escalate. From 6 to 8, it becomes 8 to 10, and 12 to 14, it increases 13 to 16. So if you have a pattern in your mind and a value which is the lesser one, that is for less than 28 weeks, just remember 5 to 6 for phototherapy and 11 to 14 for exchange transfusion. And for 34 weeks, remember 12 to 14 for phototherapy and 17 to 19 for exchange transfusion. You can have an idea that if a baby falls in between these values, you can start treatment earlier. Now, you might have one question in your mind: why these numbers are in range? Why the values or the threshold is in range? Why does I have written over here 6 to 8 for phototherapy and 12 to 14 for exchange transfusion? This is because of a reason that neonatal care is not practiced by reading a number in isolation. This range exists because the infant's clinical condition changes how dangerous bilirubin is. So, the table is asking you to do two things at once. First, identify the gestational age, and second, decide whether this infant belongs closer to the lower end or the higher end of the range. How to decide that the infant belongs to lower end or the higher end? This is decided on the clinical condition. So if a baby having a gestational age, let's suppose less than 28 week, but this neonate is clinically stable, you can start phototherapy at a higher threshold, that is at 6 milligram per deciliter. But If the gestational age of the baby is same, but the child is neonate is clinically unstable, you have to start phototherapy at a lower threshold. So lower threshold is for the babies which have clinical instability, and higher value is for those babies which are clinically stable. So these two values are for neonates which are unstable clinically and clinically stable. So what are the risk factors which pushes the neonate to the lower threshold? So let's discuss the risk factors which pushes the neonates towards the lower threshold. Remember, these risk factors are those which increases the risk of bilirubin neurotoxicity. Starting with the first one. First one is hemolytic disease. For all those neonates which are direct antibody test positive or Coombs positive, these babies have high risk of developing neurotoxicity because they have high bilirubin production due to destruction of RBCs. So there is increased destruction of RBCs resulting in increased bilirubin production with a greater rate. So these babies are at risk. The second one is hypoxia or acidosis or asphyxia. Those babies which have significant perinatal compromise, poor ABGAR, or prolonged resuscitation or metabolic acidosis has a more vulnerable brain. The third is clinical sepsis. Fourth one is temperature instability. Fifth one is poor feeding or a baby which is lethargic. Sixth one is serum bilirubin, which is less than 2.5 gram per deciliter. The seventh is general clinical instability. If a baby which is ventilated, having acidosis, poorly perfused, or looks unwell, so start phototherapy or exchange transfusion at the lower threshold as compared to those which do not have these risk factors. So these are the risk factors. I am repeating it again. First one is isoimmune hemolytic disease, that is those neonates which have Coombs positive, which results in more destruction of RBCs, more rapidly progression of bilirubin level. Second one is hypoxia acidosis. Third one is sepsis. Fourth one is temperature instability. Fifth one is poor feeding lethargy. Sixth one is serum bilirubin less than 2.5 gram per deciliter, resulting in decreased bilirubin binding. And fifth one, seventh one is clinical instability. If you remember these risk factors, you have an idea that you have to start at a lower threshold. And if you reverse it, all those neonates which do not have these risk factors can be treated at a higher threshold level. So, those who have no significant hemolysis, no sepsis, no acidosis, no major temperature instability, no significant lethargy, no major albumin concern, and overall a stable hemodynamically neonate. These infants can be started at a higher level of the threshold. Now, starting with a structured bedside approach, how to approach these babies. Whenever you see a neonate which is jaundiced and it is preterm infant, that is infant less than 35 week, you have to confirm the gestational age. That is, either this neonate is less than 28 week, this neonate is 28 to 29 weeks, this neonate is 30 to 31 weeker, this neonate is 30 to 33 weeker, and 34 to 35 weeker. So, if you have the gestational age, you can have an idea about the threshold values. Second, measure total serum bilirubin. So, first one, you have to assess the gestational age. Second, you have to measure the total serum bilirubin. Third one is assess clinical stability or instability. Fourth, after this, you have to decide the range. Either this infant crosses the phototherapy range or not. Fifth one, after deciding the range, that is calculated serum bilirubin, this is total serum bilirubin. You have to decide either this baby have crossed the phototherapy limit or threshold or the exchange transfusion threshold. And the most important, always ask why the bilirubin is rising. This question is important. You have to calculate the rate of bilirubin which at which it is rising. Is this prematurity alone, or is there hemolysis, sepsis, any bruising, poor intake, temperature instability, or any other factor which have led to increased bilirubin? So, you have to approach in this manner. First, the gestational age. Second, the total serum bilirubin. Assess clinical stability. Then, in which range or threshold the neonate is falling. Is it crossing the phototherapy range or exchange transfusion range? And why bilirubin is rising? Is it due to hemolysis, sepsis, temperature instability, poor feeding, or something else? After this, now moves towards the investigations. Investigations which are required over here, the first and the most important is total serum bilirubin. In babies under 35 weeks, this is the value you rely on. So you have to check total serum bilirubin, not the transcutaneous bilirubin. Remember, you should always check total serum bilirubin instead of transcutaneous bilirubin to decide whether this child or neonate falls for phototherapy or exchange transfusion. Do not rely on your physical signs, that is the baby looks jaundice, you started phototherapy. No, you have to rely on total serum bilirubin level. If you think there is immune hemolysis, you have to send maternal blood group baby blood group and Coombs. Check hemoglobin, hematocrit, reticulocyte count, and a peripheral smear. These all help you in differentiating either the hemolysis is occurring or not. The hemoglobin is helping. Is there any anemia? The reticulocyte count helps you judge marrow response. And the smear helps you look for the red cell pathology. If the baby looks clinically unstable, you have to send sepsis workup. You have to send serum albumin level. And if you think that the baby is metabolically compromised, you should send blood gases because acidosis increases concern for bilirubin neurotoxicity. So when you have sent all these investigations and you have the lab reports, you should have focused on few questions. Number 1, how high is the bilirubin? Number 2, is this unconjugated or conjugated? Is there any hemolysis? Is the baby is in sepsis? Is there is decreased albumin level? And is there any acidosis or any clinical instability? So, whenever you send these investigation and you have the lab reports, you should have these questions in your mind. How high is the bilirubin? Is it falling in the threshold of exchange or phototherapy? Is this unconjugated or conjugated? This is very important because unconjugated bilirubin crosses the blood brain barrier and this can lead to neurotoxicity. And conjugated is important for the biliary atresia. Remember, conjugated bilirubin is always pathological if it is increased in a neonate. Now, after you have answered all these questions, you should have to approach for a management plan. The most important and the first principle over here is correct gestational age and bilirubin threshold. Do not compare these preterm babies with the term babies because if you look at this level 5 to 6 milligram per deciliter is can be normal for a term neonate, but it is an indication of phototherapy for neonates less than 28 weeks. Now, after deciding the threshold value, next important is this bilirubin is rising slowly or at a higher rate. Remember, if a bilirubin is rising rapidly, it can cross the phototherapy threshold and become a candidate for exchange transfusion in a very few hours. At the same time, correct the underlying contributors. That is, if the feeding is delayed or insufficient, then increase it or improve feeding support. If the baby is septic, treat sepsis. If there is hemolysis, identify and manage it. If there is acidosis or instability, correct these aggressively. So, you have to manage all these along with this. So, feeding problems, delayed stooling, baby sepsis management. If there is hemolysis, then hemolysis management, acidosis management. Because if you don't manage these, it can worsen the jaundice more. If you have started the phototherapy, but once the treatment has started, you should check bilirubin again to make sure therapy is working. So, if the baby is on conventional phototherapy, NICE guideline recommends repeating the serum bilirubin 4 to 6 hours after starting treatment. So, it is important to check either the treatment is working or not. So, as per the NICE guideline, initially you have to check after starting the phototherapy at 4 to 6 hours and then every 6 to 12 hours once the level is stable or falling. So, at the start, you have to start repeating the labs at 4 to 6 hours. And when the bilirubin level is declining, then check every 6 to 12 hours. The next question is when to stop phototherapy. As per the NICE guideline, you can stop phototherapy if it is fall approx 50 micromole per liter below the threshold. But remember, you have to repeat bilirubin to check for rebound according to the infant's clinical situation. So, NICE guidelines suggest stopping phototherapy when the level falls below 50 micromole per liter as per the threshold. So, here in this lecture, we have dealt with preterm infants, why they are different to term neonates, what are the reasons why we are here checking or going with the gestational age, what are the risk factors, how to investigate, and how to manage. Two important points over here according to NICE guideline: when to repeat serum bilirubin after starting treatment, that is 4 to 6 hours, then after 6 to 12 hours if it the serum bilirubin is stable or it is falling, and when to stop phototherapy as per the NICE guideline if it falls 50 micromole per liter below the threshold. But remember, you have to check for rebound levels of bilirubin as per the clinical situation. In the last, what are the common mistakes we as a resident make? Number one, which is most important, we usually consider this unit as term. So, using the same values as we have the term babies for preterms, that is using NICE guideline values or Bhutani chart for risk assessment in preterms. Remember, those are not for preterm babies. The second mistake is treating the upper end of the range using upper threshold for everyone. for every preterm without considering the risk factors. If you didn't consider the risk factors and you remember only the higher threshold, you may let that neonate vulnerable to brain injury. Third, just looking at the bilirubin level, not the neonate condition, preterm condition. The last one, do not consider gestational age for treatment. Do not calculate gestational age correctly. So, for a quick recap, we just done over here why preterm babies are different, because they have immature organs, they have increased enterohepatic circulation, decreased conjugation, they have different approach as per the gestational age, different values for phototherapy and for exchange transfusion. For less than 28 weeks, it is 5 to 6 for phototherapy, 11 to 14 for exchange transfusion. For 28 to 29 weeks, 6 to 8 for photo, 12 to 14 for exchange transfusion. For 34 weeks to 35 weeker, it is 12 to 14 for photo and 17 to 19 for exchange transfusion. So here, for neonates which have gestational age less than 28 week, 11 to 14 is for exchange transfusion, and those which is falling in between 34 weeks to 35 weeks gestational age, this is for phototherapy. So the range is different in between this. Remember the risk factor, that is there any hemolytic disease, is there any hypoxia or acidosis, is the baby septic, is there any temperature instability, is the baby is feeding poorly. And to approach, first is the gestational age, second one is measurement of total serum bilirubin, third one is clinical stability assessment, and fourth one, the question why bilirubin is rising, is it rising rapidly or not, investigations, and all these. I hope this lecture clear your mind about the preterm neonates management related to neonatal jaundice. I didn't discuss term neonates over here and few other things, just like what is unconjugated bilirubin, what is conjugated bilirubin, which point you should ask in history, how to assess or investigate in stepwise approach. All this will be discussed when I will deal neonatal jaundice in term units. This is just for preterms. I hope you have a clear no, you now have a clear concept for this. If you have any query, you can ask me in the comment box. One more point, which is more important, all these lectures are prepared using standard textbooks and standard guidelines, which are recent. But these are only for professional. If you have any query or you have any values difference in your clinical practice, follow your local guidelines. These lectures are only for educational purpose. Thank you. Allah Hafiz.